This is a patient with a hypermature, fibrosed, very dense cataract. His vision is light perception in this eye. Here we're starting the rexus. The anterior capsule is leathery and corrugated, and you can see that once we stain that with trypan blue. I'm trying to puncture the capsule here, but it's difficult to actually get through, but we do get the tear started, and I can get outside this area where most of the leathery, corrugated, fibrosed capsule is thickened and start getting a tear going. And we're going to tear this around and try to stay outside that really leathery area, but not go too far out that we lose this into the periphery. And here we get a little resistance, but I'm able to kind of pull through that. There we go. I'm going to inject a little viscoelastic to flatten out the anterior capsule and try to keep tearing using a little bit of a little maneuver, pulling toward the center to keep the tear going. And when I get right to the end here, I start to get this dense band that's going out to the periphery. And if I keep pulling on that, the tear will go out. So here I'm going to use a Kugelin hook to provide counter traction and try to tear against that. But I'm still not able to propagate this tear and complete it. And I don't want to disinsert the bag or get this to tear out into the periphery. So I'm just going to try coming from the other side and see if that works, but I can sense that that's not going to work either. So what I'm going to do is pull this flat out here and use a sharp vitreoretinal scissor. This is a disposable scissor with a very sharp curved tip that I can just cut this off and sort of feather the edge here to make it smooth. Pull out this fibrotic anterior capsule. And now we're going to go ahead and phaco this dense nucleus, and I'm going to sculpt out the center using a technique called reverse slope sculpting. And the idea of this is to create a very deep central groove where I remove most of the lens nucleus the furthest from the cornea without putting much pressure on the posterior capsule or anterior capsule. I'm sort of stabilizing the lens with the Sinskey hook and watching that area I'm concerned about over on the left side as I do this. So I start sculpting, and now I'm going to rotate the lens, so I'm always sculpting against the thickest part of the lens. So I go deeper and deeper and try to get right down to where there's a very thin plate at the bottom, and I'm going to thin out this periphery here. So right here I'm making the groove a little wider and a little deeper, and I'm going to rotate the lens and go to the other side and go a little wider, a little further out and a little deeper, always in good control, never putting much pressure on anything. And when I get deep enough that I sense I can split the lens, I'm going to go out, go to the other side and finish sculpting out to where I think I can now start to split this lens. And I want to do the split away from the area that I'm concerned about where I cut with the scissor. I don't want to put much pressure in that area. So here I split the lens completely, and now I can take this half and just pull this out. And this is actually less than a half because I've widened that central groove so much. This is more like a third of the nucleus rather than a half, maybe even less. And so this phaco emulsifies pretty easily because most of the really dense central part of the lens has already been removed with the phaco tip during that reverse slope sculpting maneuver. And here's the other half. And at this point I'm going to come out and inject some dispersive viscoelastic to protect the cornea endothelium. And now we'll go ahead and chop this second half in half. And as I said, this is really less than a half. It's more like a third or maybe even less than that. And the densest part of the nucleus was already removed when I did the reverse slope sculpting maneuver. And this is the technique I like to use for these extremely dense cataracts where I'm concerned about the integrity of the anterior or the posterior capsule and I don't want to put much pressure on it. So now there's very little cortex to clean up. You can see the anterior capsule rim is intact. I'm going to use a jet maneuver to blast off the lens epithelial cells with BSS, fill the capsular bag with cohesive viscoelastic, and this is a three-piece acrylic lens I'm going to inject into the capsular bag. and you can see the anterior capsule and posterior capsule are intact. We're going to sweep the anterior capsule for lens epithelial cells on each side, so there's less chance of fibrotic contracture, reducing inflammation as well. Remove the viscoelastic. We're going to adjust the intraocular pressure to physiologic, and the case is completed. The next day at the slit lamp, his vision is 20/30 uncorrected, and the cornea looks very good. Thank you for your attention.